Good afternoon, everyone. My name is Karumanchi. I'm the Director of Renovascular Research at Cedars-Sinai Medical Center, Los Angeles. Today, we have a very interesting webinar titled Treating Recurrent Focal Segmental Glomerulosclerosis in Post-Kidney Transplant Patients. And Opus Medicus designates this course for a maximum of 1 AMA PRA category credits and ABIM mark points. The lecture is going to be given by Dr. Tarek Alhamad, who is the Medical Director of Transplant Nephrology at Washington University in St. Louis and the Director of Transplant Epidemiology Research Collaboration. Dr. Alhamad is one of the editors of the Washington Manual of Nephrology Subspecialty Consult book and the editor of Washington Manual of Transplant Nephrology Subspecialty Consult book. His research is focused on outcome studies of kidneys and pancreas transplant and finding new biomarkers of kidney transplant injury. Without further ado, Dr. Alhamad, please go ahead.
Thanks for the kind introduction, Dr. Karumanchi. Very pleased to be here today to share with you this presentation about treatment options for recurrent focal segmental glomerulosclerosis, FSGS, in post-kidney transplant patients. And would like to start with a couple of questions just to see how the pool will be going and what's the overall info. The first question, for kidney transplant patients with recurrent FSGS, which statement is accurate? I will give you a few seconds to read it. All right, so the majority, actually all the people who answered, they chose the third one, which is the right answer. Recurrent FSGS is associated with an increased risk of graft failure. We'll move to the second question. Which one is not a risk factor for recurrent FSGS? Which one is not a risk factor for recurrent FSGS? Okay. And here it seems a third of people voted for the second option, elderly patients, a third voted for white, and a third voted for pre-transplant pattern nephrectomy. We'll come to this in a few slides. One more question. Which of the following is a treatment option for recurrent FSGS? LDL apheresis, rituximab, ACTH gel, plasmapheresis, all of the above. Yeah, and I think here everybody got the question right, all of the above. Anytime we see all of the above, we choose it, right? All right, just get here back. So just to give you a scope about how glomerulonephritis is an important part of our work and in kidney transplant recipients. So around 15 to 17% of patients who are in the waiting list for kidney transplants have glomerulonephritis as an etiology for the disease. So that's a good percentage of patients. And in actual number, it's around 3,500 patients with a diagnosis of glomerulonephritis that receive a kidney transplant per year. Here, it's in the y-axis are the number of transplants, and in the red line are the number of patients with the glomerulonephritis. So around 3,500. Among these diseases of glomerulonephritis, we see a couple of them that they significantly reduce the graft survival. Compared to no glomerulonephritis, we see here a couple of them that they have lower graft survival at 5 years. The lowest one is MPGN, which also includes in that study, I think they include a couple of diseases such as atypical HUS, C3, it's all were looped in one category. And the other one is FSGS. The graft survival, if you don't have FSGS or MPGN, is around 80%. If you have FSGS, it's down to 73%. In a multivariate analysis, we could see that the hazard ratio for a graft failure is 7 times in MPGN and almost 5 times if you have a recurrent FSGS. So it's a serious disease that is impacting kidney graft survival. In terms of survival for patients who have recurrence compared to new recurrence among the FSGS, in the y-axis in this figure is the graft survival, and in the x-axis are the number of years. And here we have 3 groups overall, which has the 2 groups. The NR group, no recurrence group, and the R group are recurrence group. And we see that the patient who they have recurrence, they have 50% graft survival at 5 years compared to 82% with no recurrence FSGS. Number of patients in this study was 30 patients, which, as you know, in all these FSGS studies all include small number of patients. So it was not a too bad number. Now, what are the issues with the diagnosis? As you know, FSGS is sort of like an umbrella that has that covers a lot of etiologies, and it's sort of like more a descriptive histology diagnosis. And many diseases will end up with that diagnosis, with that focal segmental sclerosis, regardless of the etiology, regardless of the pathogenesis. They will end up all with podocyte injury and will end up with focal segmental glomerulosclerosis. So there are a lot of diseases in that category, FSGS, and many cases of FSGS are underdiagnosed. Many cases are attributed to hypertension, are attributed to just chronic scarring of the kidney without specifying the etiology. So when we do kidney transplant, few weeks later, or sometimes few days later, you see a significant proteinuria and a diagnosis of FSGS. This might be actually the diagnosis that happened before transplant and just was undiagnosed appropriately. So what are the etiologies? There are several theories behind the diagnosis of FSGS, and each theory has their own support and publications. There have been evidence for circulating factor, and that circulating factor is making sort of like a nephrotic syndrome, and it's has been shown that, which I will discuss in a couple of slides, whether it was SUPAR or other type of circulating factor that is causing the injury to the podocyte. A response to plasmapheresis is a very good clue, and LDL pheresis is a very good clue about this theory of circulating factor. There's also theories about the involvement of T cell CD34 stem cells from nephrotic syndrome patients with the proteinuria in mice have shown that positive for CD34. Response to rituximab also is a clue and a hint that for B cell involvement. Regardless of the etiologies, it seems that all, at the end of the day, they share the same spot for injury, which is a podocyte injury. This circulating factor interact with the podocyte, causing the injury, causing that slit diaphragm with the loss of nephron and podocyte, and to end up with the effacement of food processes. Here are the known risk factors for recurrence after kidney transplantations, and these have been obtained from a multivariate model where they include several factors, and they end up with that these factors are the most important, that includes higher hazard ratio for recurrence after kidney transplantation. First one is recurrence in a prior kidney. So if you are looking for a second kidney transplant, and the patient has already a recurrence in the first kidney, the recurrence rate for the second kidney will be quite high, almost up to 100. And I think this is important as we discuss with our patients, that you are very likely to have a recurrence in your second kidney. In particular, this will be important for patients who lost their first graft within the first few months after kidney transplantation. Younger patients at the time of diagnosis, short period between the diagnosis of FSGS and the incidence of dialysis, which is a clue of the severity of the disease, high proteinuria at the time of diagnosis and pre-transplantation, white recipients, and pre-transplant bilateral nephrectomies, which is another sign of the severity of the disease. Removing the kidney will not make any difference. It's just a sign that this disease has severe proteinuria, that those patients ended up with bilateral nephrectomies. How could we prevent the recurrence of FSGS? Is there anything we could do at the time of transplantation to prevent the recurrence? I'd like to use this paper, was published 3 or 4 years ago by the Hopkins group led by Sami Al-Asfar. And I'm taking this actually from their abstract. They included 37 patients with FSGS who received preventive therapy with a plasmapheresis and or rituximab, compared to 27 patients without preventive therapy. And they concluded that, looking at the rate of recurrence, that both or either did not decrease the recurrence rate of recurrent FSGS. We did also a single center analysis, and we found the same thing here in our program. Despite that, we still actually give a low dose of rituximab, 200 milligram, just trying to decrease the recurrence, although we have shown it's weak evidence, very weak support, but as the disease has very bad outcomes in the kidney transplant, we're just trying to see if that would help. Further analysis is just pending. In terms of treatments, so there have been several treatment options. Not all of them have great results. These treatment options have been able to treat some patients, but not all of patients, which goes back to the idea that this FSGS has many diseases under that diagnosis. Plasmapheresis. Usual typical therapy includes 1.5 plasma volume for 5 sessions within 1 week, sort of like an acute pheresis, and then followed by once or twice a week. And there have been several studies, and we look at the number of patients that are included, as we discussed before, all a small number of patients in the studies. And this meta-analysis found that around 63% of adults would have some response to plasmapheresis, in particular if they started early after transplantation. Another study in pediatric, and this was done also by one of our colleagues in WashU, looking at rituximab, it's included 39 patients with FSGS nephrotic range proteinuria. 34 out of 39 had biopsy-proven FSGS. Patients were on PO, steroids, and tacrolimus MMF or cyclosporin MMF. And we could see here in the table, looking at the age at diagnosis, the mean was 6, and you have the range in parentheses. 1 to 40. Age at transplant is 18, and you have the range between 5 to 48. So a good number of patients were pediatric, just to highlight this because sometimes the response in pediatric is different from adults. In their study, they showed that 61.5% presenting in the first week after transplant. In terms of outcome, 43% have complete remission. I think the definition of complete remission in that study was less than 1 gram of proteinuria, and 20% have partial remission. Contrary to that study, a paper in AJT in 2008, published by the UCSF group, they have that sort of like case series of 4 patients, and they concluded that none of the patients treated with rituximab achieved remission in proteinuria, and 1 patient experienced early graft loss. Moving to another sort of like more an old therapy, the use of IV cyclosporin. We have not used that before, and it's kind of like a little bit toxic, but I just want to review that in this paper by a single French transplant center. They were giving 14 days of continuous IV cyclosporin followed by oral treatment, achieving a high peak level between 1200 to 1400. So, and this just reflects the sort of like the kind of not having good tools to treat with FSGS. So just physicians, providers were trying different type of therapies. Abatacept, another thing that was tried before. There was some initial enthusiasm about the use of abatacept in a paper that was published in New England Journal of Medicine, where 4 patients with recurrent FSGS, they received abatacept, plasmapheresis, and rituximab, and they all 4 had resolution of proteinuria. After that, the several investigators were trying to use the abatacept or belatacept that we use in transplant, but this has not been shown to be useful. This is another study in JASN, and just reading the title with you, that P7-1 blockade does not improve post-transplant nephrotic syndrome caused by recurrent FSGS. Again, just looking at the spectrum of this disease, few patients, a couple of studies reported that this type of treatment would work. The other studies would report it's not working. I like this letter from this letter to the editor that published in Transplant International, just to show you how much therapy patients are receiving to prevent and as a treatment trial. So let's look at patient number 1. He is 63, got a deceased kidney transplant, no DSA at the time of transplant. Prophylactic treatment, he received plasmapheresis, rituximab, IV cyclosporin, and induction with thymo. Maintenance immunosuppression, tacrolimus, mycophenolic acid, and steroids. Treatment of recurrent FSGS, plasmapheresis, rituximab, galactose, in addition to belatacept that they tried in this study. And this is an example of the 5 patients that we have here. All of them, they were receiving prophylactic treatments. They were trying different type of therapies, rituximab, plasmapheresis, and with little effectiveness for preventing or treating this disease. Another option is ACTH gel. ACTH gel is adrenocorticotropic hormone that has impact on many melanocortin receptors, but the one that is an area of interest for kidney transplant is the melanocortin receptor 1, which expressed directly by podocytes. We combined 10 patients from our center with 10 patients from Hopkins in patients with resistant to the standard traditional therapy, and we tried to use ACTH gel. So it was published in Transplantation a few years ago. And here we see the outcomes. The y-axis is the response. And we see that patients who achieve complete response, defined by, I think, was a decrease in proteinuria of less than 1.5 gram. Partial remission was a decrease of proteinuria of less than 3.5 grams. So 4 out of 20 achieved for complete remission, and 6 out of 20 achieved partial remission. We considered a patient with partial remission. He did not meet that criteria, but he was weaned off plasmapheresis. In that paper, we were asked to provide sort of like a diagram of what are the treatment options and what is the strategy to approach patients with FSGS. So I would like to go with you over this diagram here. Looking at the first box in the top, no strong evidence that plasmapheresis or rituximab before transplant prevent the recurrence. For patients who have history of FSGS or any clear etiology of kidney failure, and I would like to add here, for patients also who were diagnosed secondary to hypertension, many were looped into that category, like hypertension, but in reality, they don't have hypertension. They may have other GN. So history of FSGS, any clear etiology of hypertension, we check proteinuria daily until discharge, followed by weekly proteinuria until month 4 post-transplant, then monthly till month 12. If there's any proteinuria, UPE more than 1 gram, biopsy. First, we rule out secondary etiologies such as viruses, CMV, HIV, parvovirus, PK. Medications, pamidronate, mTOR inhibitors, interferon, and the other one is anabolic steroids. In terms of treatment option, our protocol used to call for intensive TBE for 5 sessions of plasmapheresis, followed by rituximab, and then plasmapheresis twice a week and monitor for response. If no response, we would consider ACTH gel. We'll start at the lower dose and then we'll increase as tolerated. Today, I would like to introduce a new option called LDL apheresis. So what's this option? Before I go there, I would like to review this case with you from a New England Journal of Medicine. It's a case that reinforced the idea that there's a circulating factor in many cases of FSGS. In the left figure here, we have patient 1 at the top. And this is a patient who received a kidney transplant in Chicago. And shortly after transplant, if we look at the red font, we see at the red line, we see that within 2 days, he have 5 grams of proteinuria. The y-axis to the right side is actually the grams of protein, and the y-axis on the left side is the GFR. So the red line goes with the axis on the right side. So within 2 days of transplant, you have around 5-6 grams of protein, then goes up to 10. On day number 6, you have around 15-20 grams of proteinuria. This kidney, as you could see, they have done plasmapheresis here. This kidney was taken out and was transplanted after IRB approval and other required approvals from patients and family. They got that kidney transplanted in another patient. And you could see the level of proteinuria on that second patient on post-operation day 2 is around maybe 28 for a couple of days, and then goes down to 1, 2, and then goes down. So reviewing this study, just to show the principle that about the having a must be circulating factor that is acting immediately after transplant in certain cases that is leading to podocyte injury and proteinuria. So what is the mechanism of LDL apheresis? In addition to removing that circulating factor, which is a protein, what is the other mechanism that would help and makes this a possible treatment option for FSGS? We know that podocyte injury leads to albuminuria, proteinuria, and hyperlipidemia. This hyperlipidemia would lead to an increase in the free fatty acids ratio. So you have more free fatty acids, which leads to sort of like a vicious cycle of persistent podocyte damage. So when we have LDL apheresis, this lipoprotein apheresis lower lipid levels, and in theory, it will reduce proteinuria and improve renal function. So free fatty acids is not that healthy to podocytes and are not helping in cases where we have recurrent proteinuria. Free fatty acids increases the circulating angiopoietin-like 4 protein. And this protein is usually, there are a lot of different types of different associations with different diseases. But one of them, it comes from the cell injury. Whenever you have hypoxic injury, this angiopoietin-like 4 protein expression in podocytes, it induces proteinuria. The etiology is not very well known, but it could be to the increasing the modulating vascular permeability, but it's contributing to that cycle of injury and proteinuria. And we know that excessive macropinocytosis and accumulation of albumin in podocytes leading to lysosomal dysfunction and more podocyte loss. This LDL apheresis studies have been examined before in few studies, and we could see here are the number of cases. As we discussed before, all those studies include some small number of patients. Here we have 6 studies, including between 7 to 17 patients, and all of them are looking at treatment of FSGS. Look, I'm going to take you here to the line just before the end, before the summary. Efficacy rate, looking at different efficacy rates, 76, 86, 57, and looking here at the summary of increased serum albumin or reducing proteinuria. I would like to discuss more in details the last study here in this table by Hattori et al., which was published in American Journal of Kidney Disease. This study included 11 pediatric patients with a biopsy-proven FSGS who were not responsive to prednisone and cyclosporin. Here are the list of patients, 11 patients, and we look at the age of onset, and you could see that they are pediatric patients, and the onset to LDL apheresis, the time. And we look here at the proteinuria that they have. So all of them, they have severe proteinuria. The lowest one have 7 grams of proteinuria. The way how LDL apheresis therapy was initiated, they did 2 sessions per week for 3 weeks. 2 sessions per week for 3 weeks. Then 1 session per week for 6 weeks. In addition to giving prednisone 1 milligram per kilogram per day. And in this figure, we see the proteinuria at the baseline, the proteinuria at 3, 4 weeks, and end up with the week number 9. There are patients who did not respond. I could count here 4 patients that they did not have a decrease in their proteinuria. The rest of the patients, it looks they have very good response. Some of them, they have the response down to 0. I think 1, 2, 3, 4, 5 patients. And we have a couple of patients who went down to around 2 grams. So those probably 2 patients will count them as partial remission, whereas the others will count them as complete remission. Currently, actually, we are doing a study in WashU. It's part of a clinical trial, multi-center study, looking at patients with FSGS in native kidneys and post-transplant. For excuse me. For patients with native kidneys, we are looking for patients with GFR more than 45, and they have proteinuria. And for post-kidney transplant, there's no actually specific for GFR. So any biopsy-proven recurrent FSGS after kidney transplantation, we will be happy to enroll this patient and offer them this option of treatment. The study will enroll up to 35 patients in 3 to 10 clinical sites. I just want to show you here in this table how the therapy will be going. So approximately 9 weeks of apheresis procedure. It will be similar to the one that we reviewed, 2 treatments per week for 3 weeks, 2 treatments per week for 3 weeks, followed by 1 treatment per week for 6 weeks. And then we are the follow-up proteinuria, and we look at all the things that are needed. This is my presentation. I will be happy to go over these questions that we reviewed initially, and then we'll go over your questions. Please, if you have any question, have it in the question and answer section in that box of chatting, and we'll go over them in a minute. So the first question for the people who were late in joining, for kidney transplant patients with recurrent FSGS, which one is accurate? Recurrent FSGS is not associated with graft failure. That's wrong. We have seen that it significantly increased the risk of graft failure. Recurrent FSGS has better survival than de novo FSGS. This is not necessarily true. Recurrent de novo FSGS could be as bad as recurrent. FSGS is associated with an increased risk of graft failure. This is right. The other question that we reviewed, which one is not a risk factor for recurrent FSGS? And the wrong answer is number 2. Young patients have higher risk of recurrence compared to elderly patients. White recipients had higher risk compared to African Americans, and pre-transplant nephrectomy, as we discussed, is just a sign of how bad the disease was at the time of diagnosis. Moving to the third question, which of the following is the treatment option? You all the people who answered the question were right at the beginning. All of these are possible treatment options for recurrent FSGS. I think we have one more. No, I think that's it. And we'll pass it now to my colleague for some reminder about the CME.
Thank you very much. And so I just wanted to get the discussion going. This is, you can claim your CME and ABI mark credits by logging on to Opus Medicus. You can also redo the lecture if you wanted it. It's there, right there. So that it's just a pretty straightforward link. But let me see if I can get a couple of questions. Then it's obviously a very interesting area. It's a very heterogeneous disease. In your own practice, when do you decide, of the FSGS that's happening post-transplant, that this is somebody that I'm going to do, LDL apheresis or plasma apheresis? How do you go about, what's the decision point in your mind?
Yeah, so that's a good question. So we already tried to give rituximab at the time of transplant, but unfortunately doesn't prevent all the case of FSGS. So we tried first with apheresis. I think that would be the first option. And we have been recently going for LDL apheresis as an outpatient. So we do plasma apheresis in hospital, and then we discharge the patient and we hook them up with the LDL apheresis. LDL apheresis is, as we discussed, twice a week for 3 weeks, and then we go down to once a week. The other option, if we cannot get LDL apheresis, is hook them up with the regular plasmapheresis, TPE, with steroids, and we may give another dose of rituximab. We have cases with excellent response to LDL apheresis, and we have cases that responded to plasmapheresis, and we have cases that they have not responded. I think one important factor to achieve better response is the early treatment. If it's kind of like too late, there's not, once you have that sort of like injury in the glum that you could see in the light microscope as FSGS, that injury is sort of like it's gonna hard to reverse. There's nothing can reverse that injury. But if we start early, when you have that podocyte effacement by the EM, and just a little bit of maybe a couple of clumps that is showing the recurrent FSGS, it's the time where you have the chance for stopping and maybe for complete remission.
So in other words, you, as I hear from you, in your own practice, you first offer plasmapheresis, and if it still persists or if they're still not getting into remission, then you go offer LDL.
Yes.
Have you had a situation where you first started out with LDL pheresis, or that's usually you always left it for people who fail plasmapheresis?
We have tried actually in the hospital inpatient. We having some difficulties arranging that in the hospital, but for outpatient, we are able to get that as a first option for treatment. So it depends on logistics. For outpatient, we have tried that as a first option. Yes.
Mm-hmm. Let me see if there's any questions here. So a question about LDL pheresis. What is the, is there a biomarker you follow? Since LDL is removed by LDL pheresis, could you use that as a biomarker to know that your therapy is actually working? What do you use in clinical practice?
Good question. Now the LDL will go down. So we follow up on that and it will go down significantly. Now this, I don't think we could use that as a marker for remission, but it's a marker that the LDL pheresis is working and getting the LDL down. And in theory, getting the LDL down, reducing the free fatty acids will help in the process and will help the recovery of the podocytes.
Are there any, in your experience, Dr. Alhamad, are there any side effects of the LDL apheresis treatment? Since many people may not have so much experience with this treatment.
All the treatments that we did went very well. There's one precaution that we need to stop ACE inhibitors 48 hours or even few days before the treatments. We have one patient that that developed a rash, and it's kind of like allergic reaction, but was on, I think, ACE inhibitors few days before. So that's the precaution that we need to be careful about. You need to stop. I would just switch the patient to losartan or other ARBs if patient is taking ACE inhibitors. Apart from that, no impact on the blood pressure. Have not seen any other complications.
Okay, it's terrific. Is there any? You also present a bit of science early on about SUPAR and a bunch of other markers. You may have seen the recent paper on nephrin antibodies that are present in some of these patients. Are any of them ready for prime time to actually measure these biomarkers that will help you determine when to start and when to stop the treatment and how often you give this treatment? Like you would do, for example, like an ANCA level. What are the biomarkers out there that looks interesting to you?
Yeah, I mean, it would be, I think, useful to see the biomarker developed in clinical practice and to sort of like sort the patient who will be responding if the SUPAR or biomarker is going down. In practice, I think one of the two main things we're going to look at is creatinine and the proteinuria. Even if the biomarker is going down, if the proteinuria is not going down, at the end of the day, that's not going to help the patient. There are some biomarkers for kidney injury, but this like such as cell-free DNA, but I don't think this would be useful here. So at the end, these biomarkers could be used to monitor cases with FSGS. I have not used them in clinical practice, but it would be, I think, one indication or one area where we could use them is when we are monitoring these patients and they still have not got the recurrent FSGS, sort of like a marker before the storm, a marker that will tell us that this patient is probably going to have a podocyte injury and we need to start treatment early.
And this is more a question related to the actual technical details about the procedure itself. Do you typically use a central line, or do you use a peripheral? Can you use a peripheral line for doing LDL apheresis, or do you have to put in a central line, for these patients?
Yeah, majority of our patients actually, they have an AV fistula at the time of dialysis, so we could use that AV fistula for plasma apheresis. If not, then we have to do a central line. We cannot use the peripheral line for apheresis. So I think majority of our patients, they had AV fistula. So it could be one thing that, not a very comfortable procedure to put a central line, but when you are talking about saving a kidney, I think many patients would do that procedure.
No, just interested because many of the familial hyperlipidemia patients, some of those patients are getting treated with this procedure with peripheral IVs. And the question is, maybe the flows aren't as good in our patients. That may be the issue. But your experience is mostly fistula or a central line.
Yeah,
that's important for people to know. Let me see if there's any other questions. I think we've sort of clarified most of them. And the question about anticoagulation. What is the anticoagulation you recommend for this treatment? Could you use citrate, or is that a different kind of anticoagulation for this procedure?
For anticoagulation, I don't think we have used citrates. I don't think.
Is heparin the most common one that you use for these patients?
Yeah, I don't see there's any contraindication with the use of citrate, but usually we use heparin if we need an anticoagulation. So yeah, most of our practice with heparin.
Okay, I don't think I see any other questions. If not, for people interested in the CME credits, please go ahead and log into Opus Medicus, and you have to type in the 268. That's the lecture code. You will get the lecture. You can watch the lecture all over again, and you'll take a few questions, and you'll get your CME credit. I want to thank Dr. Alhamad for a fascinating lecture. He has given us very different options for treatment with this recurrent FSGS. It's still a huge problem. So thank you all. If there's any other questions, please feel free to email Dr. Alhamad directly at Washington University. Thank you.
Thank you, Dr. Karumanchi, for moderating this session. Thank you.
Thank you.